We will call the meeting to order. You received copies of the minutes. Any corrections or emendations? Not, floor is open for a motion.
Motion to move.
Commissioner
Second.
Nissen, second. Commissioner Ahmed, discussion? Hearing none, all in favor say aye.
Aye.
Opposed, same sign. Motion hereby carried. We have no agreements and contracts. Begin general business this morning, and I will call in Charlotte Hand, please. And I'm assuming, Charlotte, you will introduce your staff and Joanne as well at the appropriate times that you decide to do so.
We will be doing so, and it does say that I am up first, but Jolynn and I come up here together because we come as a package deal. We have two units that are different, but we intersect in so many ways that we really treat our two units as one unit. So like every other week, we meet together as two teams, and then the opposite weeks we meet as our small teams to go more specific into our specific duties. But we're up here together because that's how we work, is very close together as two teams. So we will be introducing you to our staff. We think it's important that you see the people who do the very hard work of child protection, intake, licensing, and all of what we'll talk about today. We've provided you with our annual report. But we won't necessarily be going through it. Hopefully you've had a chance to take a look at it, or if you haven't, as you look at it, if you have any questions for us, feel free to ask them as we talk about each of the roles our units have, or save them for the end, or as always, you can ask a question anytime during the presentation that you would like to. A couple things we'll touch on before we start going. How we're going to handle this is we're going to go through what happens in my unit and what happens in Jolynn's unit. And they just flow one into the other. But before, we'll talk about a few trends that we mentioned in the annual report. As we've talked pretty much every time we've been up here, a trend that leads many families into child protection is the use of drugs, and primarily the use of methamphetamines. Those are some of our most difficult cases to get parents to engage in, because meth is a drug that basically, it was originally, when it became such a big epidemic, it was talked about as the walkaway drug, because it becomes such an obsession that parents do walk away from their responsibilities, including their children. And so it takes a great deal of work to help them get on the right track, abstain from chemical use, and be engaged in working with their kids. So that's one of the trends.
In my unit, we had a significant increase in truancy referrals this year, about 100 more truancy referrals than we had last year, which is a significant increase. With that said, though, Becky Anderson is our truancy worker, which I'll go more in depth later, did a very nice job of not filing a lot of truancy petitions. So she got all those referrals and was able to sort out the priorities and engage those children to develop a plan to get to school regularly. So our number of truancy CHIPS petitions didn't increase significantly, but our referrals did. Another trend in my unit and Char's unit is we're using a lot of relatives for placement. We've had a big push to use relatives, and we're doing a good job with that. The problems that come with that and the drug use are we can have relatives down in Rochester and we can have a parent at chemical dependency treatment in Grand Forks. So that leads to some huge challenges for the social workers, because they have to do at least weekly visits with these kids and parents. So they're going to one area of the state and bringing children to another area of the state. So that's led to a lot of travel time and some problems that way.
One other thing that recently began, I believe it was last July, is child protection. The county child protection agencies are now responsible for assessing reports that involve sex-trafficked youth. And the reason that's different is because in sex-trafficked youth, most of the time, the alleged perpetrator is not a parent or is not a household member. That's who we've traditionally assessed, is parents and household members who act in a caregiving role. But sex-trafficked youth, by the federal statutes, is now mandated to be investigated through child protection. And that's added a little bit of a different twist for us, because we're now investigating a perpetrator, again, like I said, outside of the household, and that can be quite an involved criminal investigation where we have to be careful that we're not interfering with the criminal investigation, but working side by side with them, with our primary focus is safety of the sex-trafficked youth. We've been operating it under statutes in Minnesota that don't fit with that type of investigation, and I've been happy to be involved in a work group with DHS where we're working to develop a third track of how we address these cases specific to sex-trafficked youth, so that we remove some barriers that are things such as, there's a requirement in all investigations that we interview the alleged perpetrator. Well, in sex-trafficked youth, law enforcement may not want us to interview the alleged perpetrator. That could impede their investigation, but as we're set now, we can't close a case without interviewing them. So the new track is really going to be that focusing on the safety of the child, not so much as we won't have to make a determination on the alleged perpetrator. The other thing that we'll be referring to later in our presentation, and I think on page 6 of your materials, there's a little sidebar that talks about signs of safety and our use of signs of safety in our work. And we're going to focus on that specifically a little later in the presentation. So I'm going to start with my unit. We're called the Intake, Licensing, Child Protection Investigation Unit, kind of a catch-all for several things. And I'm going to start with licensing. And so when I introduce my staff, I'm going to ask them to tell you how long they've worked here. And so when we talk about licensing, the first thing I'll talk about is family child care. And our licensor for that is Amanda Lager. And Amanda, how long have you worked here?
11 and a half years.
So Amanda's been here 11 and a half years. She was originally doing child protection assessments. And did you start in ongoing child protection, Amanda?
Yeah, I did ongoing 2 years and then child protection assessment investigations until October of 2017.
So she's got a good background in that, and then now she's doing family child care licensing, and she's taken that and made it her own project, and she's doing a great job in working with licensed child care providers. As part of that, both Amanda and I are part of a core group from Candiota County that's looking to address the shortage of child care slots in Candiota County. It's a core group that's organized by First Family Finance, and it's an amazing group to be a part of because it's a great cross-section of our county, and there's a lot of steps being made to move forward with securing additional slots. And part of what Amanda does in that is look for creative ways that we might be able to use family child care other than the traditional provider in their home. We can look at maybe a family child care where, say, a church sponsors it, and it's located in the church, but it's a family provider type thing. Next in my unit is Constance Nelson, and has she made it up yet? Constance is our foster care licensor. And what I'll tell you is all of the staff in my unit are also backup intake workers, which mean they take the intake phone calls requesting services, child protection reports, walk-ins, et cetera. And just before she came up here, she ended up with a walk-in. So when she comes up, I'll let you know who she is. Constance licenses traditional homes. She has a role in corporate foster care. We used to license corporate foster homes. Now our role is more that of making sure the, I can't use the word, she's more about the making sure the structure, she's not doing the full licensing. It'll come to me in a minute. But for her primary thing is doing family foster care. That's where bulk of her work goes to. And when she's doing that, like Jolynn said, we have traditional homes, which she's constantly looking for new traditional foster homes, who are people who just go into it for the purpose of being foster parents and hopefully being willing to adopt children as part of that. But the biggest trend is, like Jolynn said, we're using more relatives all the time when we place children. And so she's licensing relatives that live in our county for our cases, but she's also licensing relatives who live in our county who are resources for other counties. So it might be somebody in Hennepin County whose aunt lives here and is going to be foster care provider and possibly adoptive parent for a child, so she's licensing them. So it comes with a lot of added work because those are not typically people who are prepared to do this. And there's a lot of steps that are involved in that, and on cue, Constance just walked in the room. So, with that, Constance, how many years have you worked with the agency?
Just about 6.
Just about 6, and you've done ongoing child protection, you worked in the home and community-based unit, back to working family assessment, and now foster care licensing. And so we're very pleased with her breadth of experience, which has been quite helpful. Physical plant, that's what she's responsible for, the corporate foster homes, other than the child homes that she licenses.
Mr. Chair,
Roger, please.
what's a corporate foster home?
Divine House, supportive lifestyles, those situations. So then I mentioned intake, and intake is what a lot of time is spent in my unit. Intake is taking all of those phone calls that come to the agency that are requesting services. They might want adult mental health, children's mental health, child welfare, looking for resources. I don't know where to turn, and a bulk of them are child protection reports. And so our primary intake worker is Michelle Wenberg. Michelle, how long have you been here?
17 years.
17 years.
The end of
The end of this month, and you've done child protection, you've done children's mental health and assessments, and now you've been doing primary intake for
6, 7 years.
6 or 7 years, and I'll tell you what, at the time when she moved into primary intake, all of us within the intake unit had the option to move in to be the primary intake worker, and you would think, well, why wouldn't you choose that as opposed to going out and doing child protection investigations? I'll tell you why. Her job is really hard. She is answering those phones. She's being pleasant to everybody she encounters, and she's a wealth of resource information for those coming to us. But really, all of our social workers on my team help with covering intake. We have a commitment in Candiota County that if you call to make a child protection report in particular, you're going to be connected to a live body. And so if you call and say, I need to make a child protection report, they'll buzz Michelle. If Michelle's not available, one of the other workers is the backup worker, intake worker. And so they have a handheld phone, and if Michelle's busy, it goes directly to the handheld phone. If that worker's busy, it goes directly to a second handheld phone. And if that worker's busy, all the phones in my unit ring at one time, so that somebody answers the phone and takes that call. We find that to be something that we're very committed to, because I'll tell you what, I have called other counties and tried to make a child protection report and got a recording. And it's like then trying to connect by, oh, they'll call me back, but then I'm not available, so I have to call them back. To me, it's just not the type of customer service we want to provide in Candiota County. So I said that all of my social workers cover backup intake, but I'm going to reference at this time Luann Grun. Luann? How long have you been here, Luann?
28 years.
Luann has been here 28 years. Have all of those been, well, intake unit really only was created 20-some years ago, all been in the same unit, basically? All right. With that, she is a wealth of information, as with our case aides. We know that if they just suddenly weren't here, we would be like, oh, crap. Sorry for the word there. But Luann helps cover backup intake for us. That is typically not a case aide position, but she is so knowledgeable of what we do in our unit that we have put her in the rotation for covering it, and she does a very good job, and we so appreciate that. And so before going on to the next step, I'd also like to introduce Cindy Casanova. Cindy, how long have you been here?
It'll be 8 years in December.
8 years in December. Cindy is the office support that's embedded into our unit. She provides office support duties across the social service area as needed. She's also one of the agency interpreters. So Cindy is very fluent in Spanish, and we use her a lot. especially those walk-ins who we need an interpreter sometimes with family meetings, sometimes with support meetings. She translates documents for us, and we so appreciate having somebody embedded right back in social services. So what happens, those child protection reports come in, and then what we have to do is we have to screen them. Screening means we have to decide what we're going to do with them. Do they get screened in as child protection? Do they get screened out? If they're screened out, it might be a law enforcement assist. It's not a household member, so we're helping law enforcement with interviews. It might not meet child protection, so we're going to do a child welfare assessment where we just go out and talk to the people and let them know there's been a report. How can we support them? If it's regarding prenatal exposure to drugs or excessive use of alcohol, we do prenatal assessments, and that would be, there she is, Brenda Sondrel. Brenda, you've been here how long? 12 years. Brenda does our prenatal assessments, which is so helpful. We intentionally did that because it's nice to have somebody who's not child protection related doing it, because if it's one of our assessors, they might approach that differently. And her role is to try to help them get off of the drugs or refrain from alcohol for the duration of their pregnancy. So if it's screened in for child protection, we have 2 tracks that can go: family assessment or traditional. Family assessment is a little bit more about engagement. Interviews aren't recorded. We don't make maltreatment determinations. If they do a family assessment and the family needs ongoing services, that worker keeps the case and does the family assessment case management. And those staff are Dylan Betker. Dylan's been here 4 years. Melanie Evian, who's been here 1 year today. And Sarah Banks. Oh, who's not here today? I don't really know how long Sarah's been here. 7? 5. And Sarah's worked across a couple different units also. Also, the possibility of doing family assessments or traditional investigations is Sherilyn Molden. Sherilyn, you've been here?
23 years this week.
23 years this week. We'll introduce her again later. She's going to help talk about the signs of safety. And then investigation staff. Those who do the child protection investigations are Carly Kranz, who's been here
3.5 years.
3.5 years. Tammy Nielsen,
Just over 5 years.
just over 5 years. And Tammy's done both traditional investigations and
Family assessment and adult mental health.
adult mental health. Carly also has done ongoing child protection in addition to doing traditional investigations. And Alicia Sweet, who's been here?
5.5 years.
And she's done ongoing child protection, vulnerable adult protection, family assessments, and now pretty much full-time traditional investigations. So when a traditional investigation worker makes a determination that the family needs ongoing child protection is when that case moves on to Jolene's unit. So now we'll move on to Jolene.
So when that case comes to my unit, it goes to one of 9 workers who do ongoing child protection. So I'll start with introducing the workers and I'll explain a little what they do. So Tammy Thompson, you can stand up. And how many years have you been here?
18 years.
And Tammy has done children's mental health and ongoing child protection. Anything else?
Traditional assessments.
Oh yeah, and traditional assessments. I forgot about that. Kelsey Thompson, how long have you been here?
A year and a half.
Leanne Kitzman,
4 years.
Christina Jones,
I was here for 3, and then I took a little break, and I've been back for 3 months.
Christina has done traditional investigations and ongoing case management before as well. So Haley Condon,
Been here 3 years.
Caitlin Colleen,
1 year next month.
Kelsey Jones is at court today. Chelsea Whitcomb, she's not here. She's at court as well. And Abby Batten, she just started about 2 months ago or so. And so she must also have gone to court with them. So what the ongoing workers do is they work with the families to provide case management services. So SHAR's unit typically identifies what the risk and safety concerns are. And then my unit works to basically get rid of those safety concerns. So they team with the family to come up with a case plan and service ideas that is made by all of them combined. It isn't just the social worker saying, well, you need to go to chemical dependency treatment or you need to go to therapy. It's really figuring out what will work for that family and then implementing those things so that you have long-term change. Some of those kids that they work with are already in placement, or some might go into placement while the workers are working with them. If that happens, they're obviously working towards reunification, so getting the kids home into a safe home. But at the same time, they're working on finding the children a concurrent home that's willing to adopt them if they can't return home. So that kind of becomes difficult at times, and parents become frustrated with that because you're working towards reunification, yet you're working towards adoption. So parents don't like to hear those things or see those things in the case plan. So it takes a lot of finessing and explaining why we do 2 roles at one time. If the child is removed and cannot return home, within 12 months, the social workers file a termination of parental rights petition or a transfer of custody petition, most commonly a termination. The state DHS does not like us to do transfers. They don't see that as a permanent option because if they disrupt, then you're back in the same boat of terminating parents and addressing those concerns as the past. So we do mainly termination petitions. If that termination petition is granted by the court and parents' rights are terminated, then the case is transferred to an adoption worker who is Tina Magas. Tina, how long have you been with our agency?
20 years.
20 years. So Tina does a variety of paperwork to get those children adopted. She does a lot of educating of the adoptive parents, what it might be like when this child is adopted, some of the struggles they may see throughout that process. Tina really is a state expert on adoption. Many of our surrounding counties utilize her expertise, and I get several calls about her excellent work and knowledge in that area. So she's been a real leader in that area. Then we have Becky Anderson, who I referenced a little bit ago. Becky, how long have you been here?
I think it'll be 32 years.
And you started in assessments?
Oh, no, I actually people with disabilities and then those fund areas of protection.
Becky's not going back to assessments, we know that. And you've done truancy for how long? Okay. So Becky, along with Tina, has become a real expert in the truancy world. The partnerships that Becky has formed with school are key to this being successful. Not every county does it the same way as we do. Our goal is really when we get 3 referrals, Becky tries to make contact with those families and figure out why aren't these children getting to school? What are the barriers or the problems that are creating this before it gets to 7 absences, where that's usually a time we would file a truancy petition in court. So the goal is to prevent that, and Becky does an excellent job. I think last year there was 369 referrals, and only 4% of those went over for a truancy petition. So that's a pretty good outcome of not going to court and children having more successful educational outcomes. So the partnership with school is so key there, and Becky's worked really hard on that. And then Brenda Sondrel, she was already sort of introduced, but Brenda works in the minor parent program. And so Brenda sits over in public health, which is kind of unique for us. She's kind of, I don't know, maybe a liaison to the social services world in public health. And so, but she is also part of our team because a lot of our cases cross. And so it's important that she come to our team meetings as well. So with Brenda, she gets minor parent referrals. So if there's a minor parent that gives birth at the hospital, she gets notice and then is required to meet with them within 3 working days to assess kind of what their living arrangements are, who they have for supports, what their education or employment plan is, looking at daycare resources, and then she can continue to monitor them as they're a minor parent and going to school. So that's been a key. We've seen the minor parent births going down, which is a good thing. So that's positive in that realm. And then I have Jody Fernholtz, who is our case aide. Jody, how long have you been here?
Almost 34 years.
And Jody does a variety of things. I mean, I can't even explain all of them, but she does a lot of our placements, our 4E, tons of discovery, and just a bazillion other things that I don't have time to totally go into. And then we have Terry Schneider, who is our office support. I would say Terry's been here for how long?
4 very fast years.
Yeah, that's gone fast. And those two are the glue that keeps our team just really running in good form. They assist the workers. They do a variety of tasks for the workers that they just would never be able to get done without them. Terry does a lot of reminders of our unit, things that need to be done because the state continues to add requirements and paperwork, things which take away from the social work time. So we've built in some reminder systems and those things. And then Terry also works on our crossover grant as well that we have with corrections. So that's my unit in a nutshell. We went through it pretty fast, but next we're going to have Sherilyn Molden talk a little bit about signs of safety. Signs of safety is an approach you've heard us talk about before when we were at board. It is really about engaging families and building upon their strengths. We use a variety of tools such as forensic fact maps, safety networks, words and pictures, and really building on utilizing their supports to help hold families accountable and support them to be more successful. I don't know if there's more that I...
No, I think you hit it in a nutshell. Signs of safety, it's a lot of upfront work, and making that shift to doing signs of safety work was a work in progress for us because it does take a lot of upfront work, but it has down the road such huge payoffs that once we committed Sherilyn to being our signs of safety guru, is what we're going to call her, we have seen a significant change in our work. So we'll just kind of let Sherilyn take over for now for a little bit. Before she does that, I was going to introduce one more person. In the room, we have Jackie Thorson. Jackie is an intern from St. Scholastica. She's with us Monday through Wednesday. Candioi County uses interns almost every semester. Once in a while, we have 2. And when I say that, I want everybody behind me who started as an intern with Candioi County to stand up. So we get good interns, we work them hard, and we're grateful when they come back to us and become employees. So Sherilyn.
Thank you. Good morning. I'm just going to focus today on basically safety network meetings because there's a whole lot more to signs of safety and it's too difficult to explain. So basically what are safety and support network meetings? We are asking the people that come to us, the families, it could be truancy cases, children's mental health, foster parents even, to gather their support people around them to make a good plan of support and of course safety for the kids and child protection. Basically it's a hard ask. Like a lot of people do not want to bring anybody else into that because they are maybe in child protection, they're having problems. It's embarrassing. They don't want other people to know their business. And so sometimes it's hard conversations with these people to get them to come to the table. So really the way we start is by all of these people having good relationships with the people they work with. So if they have good relationships, we're much more likely to get these people to the table. So basically what happens at a safety meeting, the best way to explain it is to do something interactive. So that's what we do in signs of safety is we ask questions. We don't talk to people. We just ask about it. So basically show of hands, who likes caffeinated beverages or drinks them from time to time? Coffee, tea, anything like that, soda? Yep. Okay. So basically if you all of a sudden today, your doctor told you that you had to stop drinking caffeine, period, because you started a new medication. Would that be super easy for people or maybe a little bit difficult? It's hard, right? Okay. So that's kind of what child protection does, is that all of a sudden we come in and we say you have to stop doing this behavior, and maybe you've been doing that behavior for quite some time. So basically, if we were to do that, Jolene, can I ask you, do you drink any caffeinated beverages?
Oh, yes, I like Mountain Dew.
Okay, so Mountain Dew it is, all right? So Jolene, If that scenario played out, what if your doctor said, in fact, if you keep drinking caffeine with this new medication, that you could start seizures, that you could actually get violent because of the side effects? Would that be like more easy for you to quit or less easy?
Oh, I don't know if it'd be either. I like pop, so if I
Okay.
quit drinking pop, I would have a headache, and I don't know, I'd probably be more sluggish, I guess.
Okay.
I think, maybe not. And I've tried before, so I don't know if it would matter because it would be stressful in both ways.
Okay, so if we were to offer you or your doctor, whoever that is, like a way to help you, like gather your people that care about you most, to do a plan or a meeting to help you quit Mountain Dew, would you do it?
Yes.
Okay, so who would you invite to that meeting and why?
Probably these people, my coworkers, because they see me drink pop all the time. I don't drink it at home, only at work.
Okay, good.
So I'd have some of these people and maybe my husband and kids.
Okay, perfect. So say, for example, we would have this meeting to help you, Jolyn, and similar to child protection, that again, we're asking someone to like stop something that's very hard. And so if we, get Jolyn to the table, that's awesome. We would work with her, support people about that. So if we'd have a support and safety meeting for Jolyn with this problem or a child protection client, basically we'd start with ground rules that we'd ask that they be super respectful because this is a really hard thing that Jolyn's going through. It's a private thing for her, perhaps even. So we would definitely, set the stage as far as the meeting goes that we will not accept any like hurtful language or people that are just there to, find out what's going on. So we set the stage with ground rules. So we definitely start with strengths. And again, we use the questions approach in safety meetings. So we'd start with, tell me, Jolyn, what are you doing already to cut down on your Mountain Dew drinking?
I don't have any pop at home, so that isn't even a temptation there.
Okay, excellent. So that's a strength. Basically, what is your motivation to stop?
Well, I don't want to have these seizures and those types of things, so I need to stop.
Okay, awesome. So again, another strength. So definitely start with strengths and build off of those in a safety plan. So once people have like a huge list, and definitely we write on walls and whiteboards and things like that so people can see we're not just paying attention to the worries, we are paying attention to what people are saying about what's going well. So once people hear those good things going on, we move into the worries. So we're very clear with people about what the county is worried about. So if we were to say something like, Jolyn, your doctor's very worried about you. If you continue to drink Mountain Dew, that you might have seizures, you might get violent, you might hurt people around you, and you might not work for the county, and that would be terrible. Yes. So, right, that's exactly what we're worried about. So we also open it up to other people in the room, like family, friends, coworkers could say, what are your worries about Jolyn if she continues this behavior? So it's an open forum to talk about worries in a safe way.
I think often what's surprising is family members bring up worries that we hadn't even thought about,
Yeah.
As well as strengths.
as well as strengths.
As well as strengths, that's true.
Yes.
Okay, so then we move into the safety planning, like we call them triggers, like something that might send Jolyn off track. So Jolyn, can I ask you what might be something that would immediately want you to drink a Mountain Dew?
Going out to eat because I like to have pop when I go out to eat.
Okay, excellent. How about, are there certain people, places, or things that you shouldn't be around because you're much more likely to get a Mountain Dew?
Well, I shouldn't, when I'm stressed and I want to pop instead of just drinking water. So when I'm stressed out, those kinds of things
Okay.
happen.
Excellent. So we do a lot more planning around the triggers and conversations about those. So then we move into what's called a prevention plan, basically like what everyone can do to help stop the worries. So including Jolyn, like what's one little thing that you could do in the next week to help reduce your drinking of Mountain Dew?
If I bring a bottle of water to work, that would help. Or if I just don't buy pop, that's a good thing for me.
Okay, excellent. And how about, I would be asking her supports, what can you do to help Jolyn stop drinking Mountain Dew? And maybe that's, checking in with her every day, whatever that plan is. So then we move into what's called the red flags and warning signs. So essentially what they are is what people look like when the worries come back. So in Jolyn's case, what would everybody notice about you if you started drinking Mountain Dew again?
Well, they'd notice it on my desk. I always have an empty can on my desk.
Okay, excuse me. So with that being said, it's a good education in these meetings to be like, if people are unaware of chemical use, for example, violence, whatever that is, we pick out those things so people get educated about what to look for in the people they care about, because some people are just naive to a lot of stuff. So it's a good way to have that conversation to talk about red flags and warning signs. We also do the response plan, basically what people should do if worries come back. And so in this case, like Jolynn, if people notice that you have a Mountain Dew can on your desk, what should they do?
They should ask me about that and how many of those I've had.
Okay, excellent. And who might be the best person to talk to you about that?
Haley.
Okay, all right, good. So again, we do a real planful and detailed plan about if the worries come back, what should we do to make sure basically the kids are safe. We might finish, and we often use scaling questions in these meetings, like 0 would mean you have no confidence that Jolynn will ever stop drinking Mountain Dew, or 10 is that you are super clear that this will never, ever be a problem for her again. So Jolynn, if I were to ask you today how confident you are in yourself, like what would you rate yourself today?
1.
And to provide a little hope, we'd say, okay, what would move you up even to a 2? Like what could you do in the next month that would help you, be a 2?
Not buying any pop would move me up, because then if I don't have it, I won't go buy it. I won't just go to the pop machine. I have to have it at my desk, otherwise I wouldn't drink it.
Sure. Okay. So that's a little snippet and really what we do at safety meetings in kind of a different scenario. So hopefully you can relate to that. Basically what I see every day along with my coworkers, because I work with a lot of them with these meetings, we work in child protection, so people don't necessarily want us or like us, and it's very difficult when you kind of throw out some bottom lines and that you have to have these meetings. So sometimes people come in angry or upset or don't want to do it at all, and often what we see is by the time the meeting is done, people have settled down, they're calm, they're laughing, which is unheard of in child protection. We've also seen really great outcomes like people requesting another meeting, people clapping after a meeting. It's very, very powerful. So any questions about safety meetings?
Any questions from board members?
I think in looking at those safety meetings, it's always surprising by the end for the person who's kind of in the hot seat at the meeting. They realize they have a whole group of support, because a lot of times they feel like they had no one. And they don't think these people will show up or that they'll understand, and they truly leave feeling like, oh, people do care. They do want to see me do better. They do recognize some of my strengths. And so building that network long-term allows us, I think, in some ways to close cases sooner, because they have that support network that they can lean on when problems come up. It allows, it has definitely made a difference in cases coming back. We don't have as many cases coming back with the same issue, because they have a network, people they can reach out to. We know in chemical dependency, people will relapse. That's part of chemical dependency, but it's all about how do they keep their children safe in that. And we've been able to plan around those things and see some real successes in areas that typically you don't.
Exactly. And I think, Sherilyn's example, we appreciate adding a little humor to it and letting Jolynn be a good sport about her Mountain Dew. But imagine that she was talking to Jolynn as a child protection parent who's chronically addicted to meth. And Jolynn giving up her Mountain Dew can sound, well, if it's here, I'm going to drink it. Imagine a drug user and the importance of, I don't want to use anymore. I'm going to treatment that can help me a lot, but I really need the support of family and friends in order to make this successful. And so just switch your mind into not Jolynn with Mountain Dew, but families who are dealing with drug addiction, or the parent who has always used physical discipline and now it has crossed the line into abuse, and we need to go, what are you going to do the next time you're angry at your 3-year-old besides hit him with a belt? And how can you use family as support in those situations? So any questions about our 2 units at all?
Not a question. Mr. Alman, go ahead.
Yeah, I think it's fascinating the work you do, but behavior modification is something we all struggle with, everybody. We all have our bad habits. breaking those habits is not, they're not easy to do, as you explained, but when you talked about people repeating the same offense over and over again, at what time do people get frustrated with seeing the neglect of the child and the parents who are not responsible? I mean, it seems like the only thing you can do is take the child away from them. And it's such a tragic thing, a very emotional thing. I don't know how you deal with it. It's disheartening to know that there's parents out there doing that. I'm not sure if they're dysfunctional, if this is a repetitive thing from family to family, or if it's lifestyle, like you said, the drugs. I don't know. It seems overwhelming at times. But this Signs of Safety program that Cheryl-Lynn was talking about is fairly new, or has it been around for a while?
Signs of Safety as a practice model has been around for quite a while. We started going to trainings on it many years ago, but the problem is a few of us would go to training, we'd be all excited about it, but we'd come back, and then the reality of work would hit us. And so, again, making this shift to a true commitment to it has been very helpful to the agency. It meant removing Cheryl-Lynn from doing assessments or investigations, because this is really full-time what she's doing. But it supports staff from both teams and all the families that we serve in the both teams. You know, and you talk about the frustrations of working in child protection, and that some parents really struggle with making the change. And that's where Julian talked about cases may go to a termination of parental rights. As frustrating as it is, the people sitting behind me, including Julian and I, we're all about hope. And we don't give up hope. And if you don't have hope, you can't work in child protection.
And I think for so many of our workers, they recognize that, you know, a lot of our drug using parents are people who were physically abused or sexually abused themselves. And so how do you help them heal from their trauma that they're using drugs to escape from? And so if you remember those pieces and are truly there to try to help them, the frustration isn't as high.
And what also eases that frustration is that all of us who have been around for a while have clients who come back that were really frustrating, but they made it, and they come back sometimes once a year, sometimes just when they're in town, sometimes they just shoot us an email to tell us, hey, guess what, I'm still doing good and I'm 8 years into sobriety. So as frustrating as we get, not giving up that hope, we know they can make it. So we do our best to strive that way.
I remember certainly, Becky, with the truancy. I remember the first presentation and discussions, and Larry, you were involved in that in the middle 90s. And the success is very clear, very, very clear at that point. But it was a leap of faith. It was a brand-new adventure at this point. And I remember the presentation that said, this is what we'd like to try. We'd like to go this particular direction. We don't know how it's going to turn out. We feel pretty confident, but we don't know. That's a positive. The Signs of Safety, looking at the motivational interviewing, the evidence-based, all of those types of, I don't even used to want to use the word initiatives, because that means something that's in a box. But it's innovations, it's the resiliency, it's hope, as you point out. They're looking at that. I know that two words that have resonated with me for the decades is burnout, particularly with the stresses, with the frustrations, and we do have a lot of turnover in those intensities. And whether it's law enforcement or if it's human services or whatever, we have that. But with the advent of and the focus on the support, the staff support, the communication, the camaraderie, it's no different, Charlotte, than when we look at the family members, because we're really a family here too. And none of us are, we're not as transparent as we should be. You know, that's human nature. We know that. But by having those connections and having that and modeling that, that emulates from all of you that I certainly have seen and known and listened to. And that's what makes the success, and that's what makes the, again, the hope and the continuation. So certainly on behalf of the board, we appreciate all of your efforts and your continual efforts and your perseverance and patience and persistence as far as moving forward in a very dynamically changing and a very difficult times. We've had difficult times forever, but I think we have a peak of difficulty in these last years with the myriad of the designers and the meth and the resurgence of that, adding a lot of frustration. And yet, I certainly, again, on behalf of the board, thank you for attending today. Thank you for your dedication, and thank you for your leadership as far as the units. We appreciate it very much.
And we thank you for your support for our staff.
I will turn to you, Jenny.
Sounds good. So I'm going to touch on a couple things related to the legislation. We started out pretty rocky. The Senate and the House were on two totally different sides. We didn't know how Health and Human Services would fare. Some things just from child protection. I think the DHS and the state is really seeing the struggles. The individuals that these staff have to deal with are coming to us with already problems. So there's going to be some funding added to the Families First Prevention Act, and we don't know exactly what that's going to look like, but hopefully we'll be able to do some preventative work, whether that's with our public health or trying to catch these families and children earlier before they come into our doors and are a part of our intake process. And then another thing is Representative Dave Baker, we really have to thank him, but they created an opioid stewardship fee. So counties are going to be able to get some funding depending on how many numbers of out-of-home placements we see that have dealt with drugs or not just opioids, it's going to be any drugs, and we'll be able to recap some of the dollars that the opioid manufacturers are collecting, and it'll be pretty much flexible spending for our child protection unit. So we're very, very thankful about that. As you heard, right now methamphetamine is a huge thing in our county, and that's really what we've seen increase with child protection. A couple other just highlights. The provider tax, we thought that was going to sunset. It did get scaled back to 1.8%, but we don't think that that will affect us. And again, that covers most of our healthcare costs and also our SHIP program, so preventative work in public health. And then the child care assistance program, that was something else that was on the table of discussion to maybe and possibly get eliminated. That is staying. We'll just see some more oversight, background checks, and integrity for this program. So one thing, I know Corinne will be speaking from a mental health standpoint in the next couple weeks, I think maybe next board meeting, but there was that federal funding got eliminated for our IMD children's Institution for Medical Disease of the Children, and that was going to be a cost shift that we would see on the county level. The state had taken it over probably until July, I believe, but then it was up for discussion if counties were going to have to take that on, and that has been sustained, so the state is going to pick that up, so we will not see that cost shift over to the counties, so we're very thankful about that. And then also, they are going to expand the PRTF facilities, so we're going to see some increased number in beds in the next couple years, and Corinne will touch more on that, but I know that that's a huge issue in our county, is trying to be able to find placement for individuals and especially our kids that are dealing with mental health issues. So just wanted to touch a couple of those highlights. We're going to have some departmental changes in our leadership for child protection, so I wanted to touch on that. Charlotte Hand, who has been a supervisor here in Candioi County, she's going to have been with us for 20 years, has put in the notice of retirement, and she will be heading on her way to her new phase and chapter in life as of September 6th, so we're very sad to see her go. She's built a really strong foundation in the staff and the department that she's supervised over the last couple years, but I'm excited to say that Jolynn Sundstrom is going to be transitioning into this unit, so she'll maintain the strong integrity that we see in our intake and assessment unit. And then the position is posted for our ongoing child protection supervisor. So we have those changes that we'll see. And one last thing, I attended a conference this last week, and the theme of the conference was calling all superheroes, and I just found it very touching and eye-opening because I think all of our staff in Health and Human Services are superheroes, but especially these individuals that are here today, child protection and child welfare staff, the amount of work and the struggles that they have to deal with day in and day out, and they're always back at work on Monday morning, even if they've been up all night and dealing with trying to place 8 kids in 3 different families and driving cross-state. So I really want to thank you from myself and the leadership team and management team in Health and Human Services that we view all of you as superheroes and continue to do what you do every single day for the families and children in Kandiyohi County.
Thank you, Jenny. Echo the comments as far as the superheroes, and the vast majority of people that we talk to as board members don't have a clue of just what you identified, the 24/7, those, whether it's a drug or a mental health or an abuse or whatever, that's ongoing, that's always there. And I know we've heard, and I've heard over the years, all of those things that we don't publicize in a sense. And yet it is real issues that are there, because that's one of those things that are just kind of subdued a little bit. Thank you very much. Have a wonderful day. Thank you.
Thank you.
And we are adjourned.